So this is a presentation on recent and emerging therapies in ulcerative colitis. And during the next few minutes, I'll be covering what we know about our existing therapies and giving you an update so that we're all on the same page there, and then also talking to you a bit more about our emerging therapies. Next slide. And next slide. Great. And we'll see if this works. Okay, so there are some themes that have emerged in managing ulcerative colitis, and for those who want to dive deeper into this, I would refer you to the recently published ulcerative colitis guidelines by the ACG, and also the AGA has recently come out with a technical review on mild to moderate ulcerative colitis. So those two references I think are very well done. I'm a bit biased, but I would say that they're a good place for you to catch up on some of how we are currently thinking about managing ulcerative colitis. But the main themes that have emerged are the separation of disease activity, how sick the patient is or how inflamed they are right now, and disease severity, which has to do with prognosis. And you heard Jean-Fred talk a lot about thinking about the patient's prognosis. The second, emphasis on mucosal healing as part of a composite endpoint for management. What we mean by that is using more objective measures of disease control in combination with symptom improvement. The third is ongoing optimization of our existing therapies. How can we make the ones we have work better? And Jean-Fred introduced that beautifully when he said that he thinks most of the therapies we have currently could do what we need right now if we could use them better. The next is recognizing the new mechanisms of some of our novel biological therapies and small molecules, as well as emerging information about how to stratify safety, just like we stratify choices of therapies for individual patients. And lastly, more and more emphasis on more targeted therapies or understanding how to use some of our less systemic treatments earlier in our treatment strategies. Our currently available medications for ulcerative colitis can be divided into the available classes you see listed here. Of course, the foundational therapy of aminosalicylates, which can be both oral as well as topical, our corticosteroids, which can be systemic, more organ selective like budesonide or topical, our immunomodulators, including our small molecules of cyclosporin and tacrolimus, 3 different classes of biological therapies, 2 of which that are currently available now and a third that'll be coming, and then a small molecule that's new, the Tofacitinib. And I'll be covering a little bit of each of these now. Of course, we recognize for many years that 5-ASA therapy is our primary approach to the management of mild to moderate ulcerative colitis, and there have been many trials that have shown that. I selected the CAM and Liechtenstein pivotal trials for the MMX mesalamine just to show you and remind you what those results were in those patients, and that although this wasn't powered to compare 2.4 to 4.8 grams, there was the ongoing discussion about whether one was better than the other, and that was discussed extensively and studied further. But I also want to point out to you that despite this therapy, which we've used for so many years, there remained a large gap in care, a large number of patients who didn't achieve remission and who didn't become better controlled. Clearly, there's a need for other therapies. Budesonide MMX has been available for some years now. Remember that budesonide, when delivered to the bowel, has a very high first-pass metabolism through the liver, so there's less systemic side effects. That's probably not the one to leave on. And it works quite well for patients, and specifically in this multi-center trial, worked well after 5-ASA therapies didn't work as well as we needed them to. Now, in sort of a prescient look at the future of what we're thinking in ulcerative colitis, you'll notice that, in fact, in this study, a exploratory endpoint was histological remission, and the histological remission numbers were actually higher than the endoscopic remission numbers, something we've seen in a number of trials and which we can perhaps talk about later, but nonetheless recognizing that this is an important endpoint that's evolving in our field. We also, of course, recognize the value of budesonide foam, and you can see across this whisker plot that it works across both overall remission, rectal bleeding scores, and endoscopic scores. So this is a very effective distal therapy that I would encourage you to be thinking about for the patients who need it. More recently, we've learned a question that comes up all the time is whether you should continue aminosalicylates when you escalate therapy to biological therapies. And specific to anti-TNF, and some recent published trials, one of which came from, in part, the Mount Sinai group and Jean-Fred, is the understanding that by the time you escalate therapy to manage ulcerative colitis to a biological therapy, if you continue the 5-ASA, you don't appear to have added efficacy over time. If you withdraw the 5-ASA, you don't appear to lose response over time. Now, this is not the same as starting with patients who are naive to therapy and randomizing them to 5-ASA plus a biologic, like a SONIC or SUCCESS style trial design. But it does suggest to you that if you want to simplify the therapy, there may not be added benefit by the time a patient has disease that has been active despite your 5-ASAs. Now, there are a variety of biological and now a small molecule therapies approved for the moderate to severe patient with ulcerative colitis, and you can see them summarized here with their clinical trial programs. I want to emphasize and highlight a few specific points for the clinicians here today. We'll talk first about the TNF inhibitors, and a reminder that we have 3 anti-TNF therapies that are approved for the treatment of ulcerative colitis in the United States: Infliximab, Adalimumab, and Golimumab. And I also want to just mention briefly that in the Adalimumab space, of course, in the last year and a half, 2 years, has arrived the citrate-free formulation that I'm sure many of you have heard about, and also biosimilars to both Infliximab and Adalimumab have been approved by the FDA, and that'll be covered in another talk today. A reminder of the pivotal trials for anti-TNF and our success rates in clinical response and remission. It can be quite sobering when you look at this, but remember that the patients enrolled in these trials were often patients who were refractory to other therapies before they got there, but also remember that these patients had disease for quite a bit of time on average compared to other patients who might have been treated earlier in their disease course. So we recognize that these therapies certainly work better than placebo. We also recognize there's room for improvement in their use. Similarly, when you look at maintenance remission rates over time, remember that most of the trials we look at maintenance randomize people who respond in induction phase, although the Act 1 and Act 2 trials were actually treat-through trials. For those in the room who understand, that means they were treated, randomized, and then treated all the way through in follow-up. But you can see here that in maintenance, we have a lot of patients who lose response, and there's clearly room for improvement in the use of these therapies or a need for other treatment options. Now, one of the things we've learned most about, and specific to anti-TNF, but it applies to our emerging biological therapies, is clearance and understanding pharmacokinetics. And we're going to have a beautiful talk on that today. Marla will really educate us more on how to think about this. I just want to highlight a couple things. We already know as clinicians a group of patients who are more likely to lose response or not respond to our anti-TNF therapy, and you can see they're highlighted there. And just to clarify, what we're talking about here, when there's increased clearance, it means decreased drug levels or decreased exposure. When there's decreased clearance, it means increased levels and increased exposure. So concomitant use of immunosuppressants increases exposure. Having a low albumin at the time you're treating the patient decreases exposure. So you can predict up front if that patient is more or less likely to clear the drug too fast and not respond or lose response soon. So this is something to keep in mind, and we've learned a lot more. We also have what might be considered a landmark study of naive patients randomized to azathioprine or infliximab or combination therapy. This was patterned exactly after the SONIC trial in Crohn's disease, and you can see that in this ulcerative colitis trial, combination therapy was superior to the monotherapies. Now, in the talk on therapeutic drug monitoring, you're going to learn that it might be the drug level that's more important than having 2 drugs on board, and we'll talk more about that today. We've also learned where the drug may be going in some of these sicker patients, especially those who have a low albumin. In this nice study from the Amsterdam group, you can see that a lot of drug was recovered in stool, and it was correlated directly with the CRP not going down. So patients who are actually leaking protein, and you can apply that across our monoclonal antibody group, you can imagine that this is why patients don't have enough drug in their system to actively work against the inflammation. It's also led to the hypothesis that treating patients who are leaking protein might benefit from small molecule treatment strategies or other treatment options to gain control of the disease before going to a monoclonal antibody after we achieve some mucosal improvement or mucosal healing. Now, The next question, of course, is whether or not cyclosporin or infliximab might be a better option in that setting. I do want to, out of fairness and transparency, show you this European trial where they randomized hospitalized patients to one drug or the other. And with the endpoint of looking at clinical remission as well as other secondary endpoints, they found that they were similar in their success rates. And in fact, the albumin in both groups was similar. So this may be counter to what I just suggested. And there's more to discuss in thinking about this overall. So if you're not using cyclo, you feel confident that your choice of infliximab in these sick patients might be right. And if you were nervous about safety, you should know safety was similar in both groups. So there's more we can learn about this. Now, the anti-integrin therapy has really offered us a nice option for ulcerative colitis and for Crohn's disease. The drug Vedolizumab has been available in the U.S. market since 2014. And a reminder that this drug works by inhibiting leukocyte trafficking. It literally blocks white blood cells who are on their way to the intestines from leaving capillaries and entering the intestinal epithelial cells. So this is a very important consideration and a different mechanism than our cytokine blockers like anti-TNF. The GEMINI 1 study was the phase 3 trial that looked specifically at vedolizumab in ulcerative colitis, and you can see that it was a remarkable study result in that the patients who received Vedo were superior to placebo across all the primary and secondary endpoints, including mucosal healing and steroid sparing. The safety of the therapy, as expected with a drug that was targeting predominantly the intestinal mucosal immune system, was very favorable as well. And in long-term follow-up of the safety of these patients, they've done quite well. In addition, this has had very low immunogenicity. Presented at DDW this year was an update on the immunogenicity of the therapy, and you can see that 4% of patients developed anti-Vedo antibodies during the long-term follow-up of GEMINI, and 5% of the patients within that group developed an infusion reaction, so very small likelihood of having those problems, perhaps less than what we see with anti-TNF, and therefore a consideration with Vedo would be to use it as monotherapy, recognizing that combining it with other therapies augments or at least reduces the safety profile of the drug. So this is very important to keep in mind and to remember about Vedo and some emerging information. Another point to recognize is that there has been no cases of drug-associated PML related to vedolizumab. This is of specific interest because of natalizumab and what we learned about that drug, which of course treats the central nervous system as well as the gut and is less selective. More recently published from our site on the left and from a multi-center effort on the right in Europe has been the concept of using calcineurin inhibitors for sick patients as induction strategies and vedolizumab for maintenance. Getting back to what I suggested, which is that in patients who are not responding to other therapies, an option would be to use a small molecule to gain control of the disease, bridge it to vedolizumab in maintenance phase. Why this combination? Well, because of the safety of Vedo, combining the two drugs as an overlap or bridging them seemed like a reasonable thing to do and in fact was well tolerated. So this may be for some of those in the room who are more comfortable thinking about tacrolimus or cyclosporin, but it certainly brings up some new treatment considerations for our future use. Jean-Fred already mentioned to you VARSITY, which was the first non-biosimilar head-to-head biological trial. This is a study that randomized patients with moderate to severe UC to either adalimumab at on-label dosing or vedolizumab at on-label dosing, with a primary endpoint of clinical remission at week 52. Secondary endpoints included mucosal healing at week 52. And what you can see if you focus on the bars on the left, with the primary endpoint, vedolizumab was superior at achieving clinical remission. There were some limitations to the VARSITY study, and it's not fully published yet for us to understand all of them. But what has been discussed is that, number one, there was no dose escalation allowed, and we recognize that many of our patients on both therapies need dose escalation for optimization. Number two, we don't have yet, and I'm not sure if we'll know, the trough and antibody levels, so we don't actually know what the overall exposure of drug to the disease was. 3, there was not a standardized corticosteroid taper. And 4, baseline immunomodulator use, when adjusted in a post-hoc analysis within the study, showed that those patients who were not on concomitant immunomodulators did better with vedolizumab compared to adalimumab, and those who were on combo immunomodulators, or for that matter on steroids, there was no statistical difference between Vedo and adalimumab. So you can keep this in mind in thinking about how you might position these therapies, as well as how you would interpret this particular and important study. Now let's move on to our emerging understanding of this novel small molecule, tofacitinib. Let me remind the room what a novel small molecule is, or at least what a small molecule is. That means it's not a biological therapy. It's a small molecule. That means that it's small enough to get absorbed through the small intestinal lining and get into the bloodstream. So it's not it doesn't have the same concerns we have with biological therapies in terms of exposure, clearance in that regard, or certainly leakage and antibody formation. The dosing that was approved for the treatment of moderate to severe UC in 2016 was 10 milligrams twice daily for 8 weeks, with the possibility of extending it for an additional 8 weeks if the patient is responding but they had not yet achieved remission, as well as maintenance of options of 5 or 10 milligrams twice daily, depending on how the patient is doing. Of interest is that in the clinical trial development program, patients who had failed anti-TNFs did better on 10 BID in the maintenance phase. And the recommendation has been to use the lowest effective dose that maintains response. Now, just to explain briefly what a JAK inhibitor does, TOFA actually blocks JAKs 1 and 3 with some blockage of JAK2. This particular enzyme is involved in the way the body turns on inflammatory cells. And as you can see here, it blocks multiple cytokines along multiple pathways. It is a potent immunosuppressant. And in fact, it works quite rapidly and it works well. You can see here the primary endpoint and the secondary endpoints in follow-up. Actually, this is just the primary endpoint of both induction and maintenance. And you can also see what we learned, and this was published by Steve Hanauer in CGH recently, which was that patients had an early response with stool frequency and rectal bleeding going down by as early as 3 days. So remember that although you have a convenient therapy in the sense that it's oral, it's very potent and it's a quick onset. And so you have to keep in mind safety when you're considering this therapy. There have been a number of other results presented, including at DDW this year as well as at ACG last year, that I wanted to highlight. The first one was that of those patients who respond but are not in remission in the first 8 weeks, continuing for an additional 8 weeks, which is on label, does achieve remission in an additional 20% of patients. In addition, those who achieve remission do better in maintenance phase than those who are only responding. Not a surprise for you to hear that, but keep in mind that we want patients to get to remission. Getting better is, of course, important, but it may not be sufficient to keep them well in maintenance phase. Remember as well that efficacy can be maintained when you dose reduce in some patients, so it's reasonable to drop the dose and follow them out longer term. And from ACG last year was this important point, which is that baseline albumin did not seem to predict a lower response to TOFA. So this is not affected by that albumin level like we see with our monoclonal antibodies, an important consideration. Now, another message that we already heard from Jean-Fred, I'll show you the data here, is that TNF-naive patients do better with TOFA or Vedolizumab. And you can see both from the subset analyses in the Vedolizumab trials as well as in the TOFA trials that the patients who were anti-TNF naive did better than those who had already failed biological therapies. Now, I want you to keep in mind that this may not be a biologic process, in other words, a pathophysiologic process. This may be as simple as the sicker patients who get in the trials and have already failed therapies are going to be more resistant to treatments of any kind. But it's an important consideration and raises the question, which therapy should you be using first in which patients? And you already heard from Jean-Fred that we're just guessing in many cases. There may be some suggestions about how to do this, and I'll give you that in a moment. Also from DDW was the summary looking at the available trials that have already been published with fecal calprotectin as an endpoint of interest. And in this summary from this nice DDW poster was that patients who had achieved clinical remission and had a low fecal calpro, meaning a normal fecal calpro less than 50, were very unlikely to have active disease when you subsequently scoped them. So in other words, it lends support to using calpro in ulcerative colitis as an additional objective assessment of disease control when you've treated your patients. And likewise, patients who did not achieve remission and had a calpro of greater than 250 were very unlikely to have endoscopic remission when you scoped them. So this drives home the point that using clinical trial data, you can rely on a calprotectin to guide you in achieving that mucosal healing or at least mucosal improvement that we're trying to get to with management of ulcerative colitis. There's a couple other tofacitinib considerations. One is the safety profile that I've mentioned already. One is related to the long-term extension results as well as real-world studies. One that's come up, of course, is related to raising lipids, which is what the bar chart shows there. It is stable, but is known that 10%, 20% lipid elevation occurs in patients on therapy, and it's recommended to monitor that. And the other is the development of herpes zoster, which occurs, it's dose-dependent, higher in the 10 milligram BID dosing, and it's also time-dependent. It goes up in the maintenance phase, although it's stable after it does that. In the real-world use, there's been less herpes zoster seen. That may be because many of us are vaccinating. We're doing that in all of our patients now. But also of interest is the monitoring for venous thromboembolic complications. There was presented and discussed and ongoing a phase 4 surveillance program that the FDA required in patients with rheumatoid arthritis who were over 50 and who had at least one cardiovascular risk factor. What emerged from this in an interim analysis, not in the final analysis yet, was an increase in pulmonary embolisms and death related to that, only at the 10 milligram BID dose, which is an off-label dose in rheumatoid arthritis. So the FDA responded by warning everyone that this was observed. It did not change the label or put a black box on the therapy, and the European agency, right in time with DDW, suggested that you shouldn't use 10 milligrams BID. Now, in our own practice, we've actually been continuing to use it at least in induction phase, and I've left many patients on it, but I am screening people for additional risks for clotting, remembering that patients with active IBD have a risk for venous thromboembolic events as well, separate from the therapy they're on. Now, remember, too, that in the phase 2 and phase 3 trials of ulcerative colitis, psoriasis, psoriatic arthritis, and rheumatoid arthritis, this signal was not seen. So we'd like to see the final results of this safety program to understand it better, but it's important for you to keep in mind. Now, the herpes risk is about 1%, herpes zoster, 1% in induction and 4 to 5% in maintenance phase, and it's stable after that. You can see over time here that it doesn't continue to go up. It's been recommended that we consider using the attenuated vaccine for patients who are receiving tofacitinib, and that has been implemented across the United States and I think across the world where the therapy or where the vaccine is available. And we can talk more about that during the Q&A. I'll remind you, though, that herpes zoster is not unique to TOFA. It occurs with our anti-TNFs as well. It specifically occurs as patients get older and when they're on immunosuppressants. Not a surprise, and I'm sure everyone in the room has had a patient who developed herpes zoster. And with the availability of the attenuated vaccine against this, I think that we should be considering this as a standard vaccination for all of our patients. Now, who would you choose for which therapy? I mentioned this earlier. Perhaps you would use Vedolizumab in your older patients as an option, or maybe even a first-line therapy when you get to biological treatments in your patients with IBD. For patients who have an inflammatory arthritis with ulcerative colitis, anti-TNF is certainly reasonable. Tofacitinib, remember, approved for RA as well as UC, a good option. And, of course, our old standby sulfasalazine may have some role. And for those with low albumin, I would suggest to you that we consider small molecules, as I've mentioned a couple times. Now, I'll just summarize in a couple slides. I'm not going into great detail all the emerging therapies in UC. You can see that we have additional anti-integrins that are coming. We have additional anti-interleukins, anti-P19 therapies, which target IL-23. We have some additional JAK inhibitors, as well as a related therapy that inhibits TYK2. And we have this S1P receptor modulator therapy that's also being developed as a small molecule. And lastly, there are some microbial therapies, both fecal transplant, which I know you've all heard about, as well as a company called Ceres Therapeutics that has developed a targeted microbial treatment. I'll only summarize this particular phase 3 study. The rest are phase 2 or earlier. This phase 3 study shows that Ustekinumab was effective for both induction and maintenance in ulcerative colitis. As you can see on the left, the induction results, and on the right, the maintenance dosing. The dosing that seemed most favorable was just like what we use in Crohn's, an IV loading dose that is weight-based and maintenance dosing that is every 8 weeks, 90 milligrams. This therapy is expected to gain regulatory approval later this year and will be another option for us in ulcerative colitis. So what we know about Ustekinumab in Crohn's will likely be able to apply equally to our ulcerative colitis population as well. In addition, a new endpoint introduced in this study was the histoendoscopic healing, the combination of both histology and endoscopy, emphasizing the benefit of that deeper remission. For those who are wondering what an S1P modulator is, just to summarize briefly how this therapy will work as a new mechanism for us, since there's multiple drugs that look favorable in this mechanism. S1P modulation is related to trapping activated lymphocytes in lymph nodes so that they can't leave and do their active work. It still enables the body to respond to other infections. So your protective immunity is preserved and can still react, but your activated lymphocytes that are going to cause or drive your UC are actually trapped in the lymph nodes. This will be a small molecule, not a biologic, and this will be a nice option when we have these drugs available. And lastly, fecal transplant, for those who want us to briefly mention it. There have been multiple studies that have been randomized with control arms that show some benefit. The challenge to all these studies, however, is that they're non-uniform in the way that the treatment is delivered, who the donors are, as well as whether or not they achieve steroid sparing. The regulatory issues are also of great concern, and the FDA has recently warned against a multi-drug resistant organism that was transmitted by a donor to a recipient and resulted in adverse events. And there are some other concerns, like how you're going to regulate this overall. So I know I've covered quite a bit for you. Hopefully I've given you a glimpse into the way we should be thinking about ulcerative colitis moving forward with our existing therapies and using them better, and our new therapies, which are going to continue to give us good options but will need to be positioned very carefully. With that, I'm going to actually now introduce our next speaker.